Okay, 9-month-old child with recurrent fever and whitish discharge by urethra, crying during void, poor stream. Male child. Who is discussing?
Sir,
Priyanku from dispute.
Okay, yeah.
so duration of the voiding symptoms.
9-month-old child. 3 months history of recurrent fever. Obviously, it is not mentioned, we will take it from birth.
Okay, sir.
What is that you want to ask? Well, unlike in adults, the history you will always ask, where does the history start in child? That's antenatal history. Was there any problem in the antenatal period?
Yes.
Okay.
I would like to know about the immediate postnatal history, sir. Whether the child is presented at 9 months or was there any previous history?
Okay. Yeah, we have it. Normal fetal delivery, birth weight 3 kg. Everything looks all right, except there is no antenatal history. Antenatal history is here.
Yes.
Priyanku, what is the normal birth weight for Indian children? Indian Academy of Pediatrics, what do they say?
Sir, it is 2.5 kg, sir, Indian standard.
So, is that important in this case?
Yes, sir.
Why is the birth weight important?
Sir, to know whether there is any small folded baby, whether it is a small folded or a preterm baby, sir.
In the light of the present situation, the present history,
yes.
How is the birth weight important?
How is the birth weight important? I mean, if the birth weight is more than you expected, with this history, what would be in your mind? What are the causes for high birth weight?
High birth weight, sir, maternal, diabetes mellitus.
Yeah, so wouldn't you be worried? This child born with a high birth weight has complaints of fever, pain while voiding, crying, post-stream. The diabetes worry you? That's the question Dr. Ganesh is asking.
Only 2 notes are positive. Only 2 notes are positive compared to the previous.
Only 2 notes.
Is Priyanku on, off?
Yes, sir, I am on.
Then answer. What are you waiting for? If you don't know, you can say don't know. Doesn't matter.
Yes, sir. No, sir, I do not say, sir.
Does maternal history of diabetes impact anything in the newborn and in childhood? That's what you need to know. Look up.
Sir.
Maybe we can move on, Prabhu.
Yeah, move on.
Right kidney epidiameter is increase in the range of severe hydronephrosis. Left kidney, it is not mentioned.
You can see the subsequent.
At 35 weeks of gestation, sir, both the kidneys are showing increased APD, that is having severe hydronephrosis. So right kidney is also 21 mm and left kidney 18 mm. So
what comes to your mind? See the 35.
sir, conditions like posterior urethral valve can present in significant antenatal hydronephrosis. So we have to look into some other factors also. regarding the state of amniotic fluid volume.
Good. Yeah.
So those can give a lead into possible signs of antenatal posterior urethral valve, and on ultrasound on further ultrasound imaging, we can if we see the findings, specific findings, then can lead to diagnosis.
So you can't say specific findings and leave it at that in an exam. What is it you're looking for? What are those specific findings?
Sir, keyhole sign on an antenatal scan, sir, that leads to specific diagnosis of posterior urethral valves.
You are talking about amniotic fluid.
Yes, sir.
What
Amniotic
about
fluid,
amniotic fluid will strike alarm bells.
sir.
And then you can go
Oligohydramnios.
on to the fetus itself.
Presence of oligohydramnios with amniotic fluid less than 500 ml volume, or amniotic fluid pocket.
If it is oligohydramnios, how does that bother you? What is its significance? That's how you have to answer, Priyanku. What if there is oligohydramnios?
So, if there is oligohydramnios, then there is a likelihood for bladder outlet obstruction in the fetus.
Why bladder outlet obstruction? Can't it be anything else?
Sir.
See, in totality, it means that the fetus is putting out less urine than would be normal.
Yes.
So is obstruction the only cause for low urine output from the fetal kidneys?
No, sir. Any congenital dysplastic kidneys or any malfunctioning kidneys also, that can lead to decreased urine volume and output, which will lead to oligohydramnios.
I think you better read up fetal renal physiology and antenatal renal physiology. Okay, because we're getting nowhere, Priyanku, with this. We can't keep saying, some abnormality, something else. Specifically, if you say, okay, 1, 2, 3, or 1 or 2 or 1, and say this is what it means, we can proceed.
See, there are two things about amniotic fluid you need to remember. One is the volume, and the second thing is the content. In the light of the current history that you have been given and all this story, it is important to know these two factors. And if you have mentioned that, then that's what is going to be of importance here, apart from the volume.
Okay, sir.
When you say content, you mean certain chemicals, certain substances which are excreted in the amniotic fluid. An assessment of those gives us an indication as to the health of the patient or the baby at the moment, in the light of all this history that is given. Both has to be taken into account. Okay. Proceed. Please. Proceed.
You want to go to examination or something more? Any details? Then, basically, you want to see whether the growth of the child is affected. The child is 9 months. Whether the child required admission. Whether the child was put on catheter or antibiotics during each of these episodes, I think was not mentioned. Anyway,
Yeah.
Yanku, do you want to know whether an ultrasound was done afterwards? Because all this is antenatal, and now the child has come at 9 months to this hospital.
Yes.
With all that finding that was mentioned in the antenatal, isn't it important to know whether something was done earlier? As soon as the child was born. That question is very important. You should ask that.
Yes.
Before you actually go to the physical examination, you still have to unearth some history. 9 months have elapsed.
If this mother had been referred to you, Priyanku, you are the urologist in the hospital, they say there's something we find in the fetal kidneys. Please tell us what we should do. And let's assume that the scan which they found is on, the latest scan was done at 35 weeks, which is the last that we have. So what will you advise and what will you plan for?
Yeah,
Sir, we have to do a repeat ultrasound, sir, to know the current state of kidneys.
No, not first of all, tell us when you want to do it. That is important.
Here the question is, at the birth, you want to do a scan at 1 month, 1 week, 1 month, whatever. That's the timelines you want to know.
I did not get, sir. The patient has presented at 9 months, sir, after birth. So I'd like to do ultrasound immediately because I don't know the previous history.
See, in an exam, you can always give you a situation and like to know whether the candidate understands the pathophysiology. Right? Let us say the child, the parents had come with the 35 weeks pregnancy. After the ultrasound, immediately they will come to you. How would you advise them? You advise them to do a scan at day 1, day 2, day 7, day 30. If suppose they are getting delivered in your hospital, what would you have done? That's the question.
Sir, immediately after birth, there should be continuous drainage of the bladder by putting a catheter, sir.
Why do you want to put in a catheter? For all you know, the kidneys might be normal after birth. So we don't intervene before we have some idea of what the problem is and how to tackle it, correct?
Yes, sir.
So Dr. Prabhu, Dr. Ganesh, all of you have asked this question in different ways. When will you do the postnatal ultrasound?
Sir, immediately after birth, sir, in the first week, sir. If there is bilateral hydronephrosis, sir, so we have to do it immediately after birth, within the first 3 days, sir. If it is birth in the same hospital.
Yeah, it depends on the sex of the child also. So in antenatal scans, I presume, I don't know the sex of the baby.
Yes.
Not knowing. You will have to answer that question. If the child is a male, if the child is a female, what do you do?
Prabhu, your mic is not very clear, Prabhu.
Okay.
Yes.
ரிப்போர்ட் நேற்று சார் பார்த்தார் சார்.
சரியா?
இன்னைக்கு உங்களுக்கு
தெரியும். இது அங்க வச்சு ஏன்னா அங்க வரும் பேஷண்ட்.
அங்கே சார்.
ஸ்மிருதி இருக்கு.
ஓகே. சரி.
எதுக்கு அங்க வச்சு ஸ்மிருதி இருக்கு.
சரி.
பேஷண்ட் வந்திருக்கா? அங்க கூட்டு அங்கதான் வரும்.
ஓகே.
Sir, anything better or worse?
No, much better now. Prabhu, much better.
Okay. So that's what. See, at 35 weeks ultrasound, we don't know the sex of the baby. Now,
Yes.
if the child was born as a female, does your management anything change? Or if it is a male, does your management change?
Yes, sir. If it is a male, then the plan of management change, sir, in management and as well as evaluation, sir.
Please tell. You can't say change.
Sir, if it is a male child, then we have to think of posterior urethral valve, sir. So we have to do ultrasound immediately after birth, ideally within the first 3 days, because there is evidence of bilateral hydronephrosis in the prenatal scan, sir.
So in these cases, what are your top differential diagnoses? Basically, we want to know that.
Yes, sir. First differential diagnosis will be posterior urethral valve, sir. Secondly, there can be anterior urethral valve, some other obstructing pathology in the urethra like polyp, stricture, or middle stenosis. The child can also be having phimosis, sir, which can also be a cause for outlet obstruction, sir.
That's all your differentials?
So,
Can it be unrelated to the outflow tract?
yes, vesico-ureteric reflux, presence of bilateral vesico-ureteric reflux can also lead to this.
Anything more? See, it can be ureterocele, it can be bilateral PUG obstruction, megaureter. So, you should be able to rattle out anatomically or as common as what it is, either one of the two. You start from the meatus and you go up, or you go, which is more common in that way.
Yes. So patient is having voiding dysfunction, sir, crying during voiding. So I didn't think of PUG obstruction or megaureter, sir. In which case,
No, see, when the child has infection, the
Yes.
child is in sepsis, they will have, you don't use the word voiding dysfunction. That word comes after the child is at least 3 to 5 years old.
okay.
A small child, you don't label it as voiding dysfunction.
Yes, sir. Okay, sir.
The children, they automatically void at this age. The dysfunction comes when they try to hold, delay the urination and all those things. That is at a much later age.
Yes.
There is some congenital abnormality in this child which is predisposing the child to recurrent UTI. You have to investigate and manage that.
Okay, sir.
Yeah, you are happy with the examination? Anything more? Or what is
Sir,
the important thing which is not mentioned here?
sir, bladder, sir, palpability, sir. There is a palpable bladder or not?
Yeah. What is that finding of sacral dimple makes you worry about?
What, Priyanku?
Yes.
Sacral dimple, man. What's the red flag there? Could there be something in the spine? Hello, Priyanku?
Yes, sir.
Could there be something in the spine?
Any evidence of spina bifida or some spinal?
No, you see, there's only a dimple there. So whatever is there is all covered, isn't it?
Yes.
It's not an obvious swelling there. So you can't say that this is meningomyelocele or something. At the moment it is covered and only there's a dimple. So it is not called manifesta, it is whatever is there is occulta, isn't it? You can't see anything what's happening. So there may be some evidence of spinal dysraphism. This is important. More important, you want to see when you see a sacral dimple like this, will you ask for anything else? You'll look for any other finding to substantiate your clinical impression.
You want to look at the perineum for something.
So, anal opening, sir.
What about the anal opening? See, Priyanku, you're making us ask each and everything, which means in the exam you'll hardly have any discussion. The exam will stop at this point. So you tell us, why do you want to look at the anal opening?
We want to know whether right in the part whether there is congenital imperforate anus or
Sorry?
Imperforate anus or
Imperforate anus at 9 months.
no, sir, at birth, sir.
So there is a dimple seen now. What else will you look for? Even if it comes earlier, let us say this child had come to you at 3 months, 2 months, whatever. What would you look for? Typically at this age, we look for something which will tell us there might be a problem with the spine.
So underlying, sir, spina bifida occulta can be there.
How will you know that unless you image? All you have here is a dimple. In a child with a dimple, with bilateral hydrourethral nephrosis, what else in clinical examination will you look for? Because that will be part of your treatment planning. Will you look for fecal soiling? Will you look for a lax anal sphincter?
Sir.
What's the difficulty, Priyanka?
Yes, sir.
See, apart from sacral dimple, there may be a tuft of hair there. You have to look for that also. You see? There could be some asymmetry. When you put the child in the prone position and see, there will be asymmetry of the buttock.
Yes.
Gluteal fold. So these are all clinical signs, that may be there in the baby. You must also remember that some of them may present with hydrocephalus.
Yes.
So these are things that you need to consider when something like that is mentioned. You presume that if there was something more serious, they would have told us, but the question is related to the term sacral dimple and the connotations. So you have to think of every possibility in the ectoderm that's going on.
Okay, sir.
So, Priyanka, you had said differential diagnosis as phimosis as a cause of the outlet obstruction. So, this finding of physical examination phimosis, does it fit your diagnosis?
See, the ultrasound is there, no? Prenatal ultrasound.
Yes.
Don't forget that, man. Correlate that with the present problem.
So, prenatal bilateral evidence of bilateral hydronephrosis is already present, sir.
I know. Does it, if you on examination find phimosis, are you worried about it?
Dr. Prabhu has just given the answer quietly.
Sir, it can be physiological.
So, up to what year you consider it as physiological?
Sir, up to 3 years, sir.
Earlier it was 2, now the recent Campbell says 4 years.
4 years.
Anyway. So what do you want to do now?
Sir, ultrasound examination, sir.
Is that the first test you asked?
No, sir. In form of imaging, that other routine blood examinations as well as urinalysis has to be done, and then I would like to go for an imaging, sir.
Can you see from there?
If there is one critical investigation that you want to do, stat, what would it be?
We said critical investigation, Priyanku, critical.
Yes, sir.
Huh? Baba, with the history of all this hydronephrosis and APD diameter, all that discussion, don't you want to know something very important at 9 months?
So urinalysis, sir.
Urine analysis is here. Is that critical? We know that the child has got an infection. The mother is saying recurrent fever and they've already said so. So the urine examination is a given, plenty of WBC bacteria, but what is a critical investigation? One wants a critical investigation.
Is there any test which will tell you this child might die in the next few hours or in the next day? That is what you want to do whenever somebody comes like this, isn't it? Is there an impending danger of worsening or death? 9 months, all this. Can any condition as a complication of all this cause death?
Sir, pulmonary hypoplasia is a
Pulmonary hypoplasia is at birth, Priyanku. This child
But
is
9 months, 9 months already, this child.
over these 9 months, it has developed something which can result in a complication that will cause death, sometimes in a matter of few hours.
So end-stage renal disease can be there, sir.
So what test do you want to know that?
Creatinine level, sir.
Yeah, is that not a critical investigation you want to do
Yes.
straight away?
Yes, sir.
The more important than critical, but than creatinine, with the history that was given to you, you must know whether as an ongoing process of renal dysfunction, when the child comes sick like this, you want to know if the child is acidotic. It's the acidosis which can kill. The creatinine may keep going for some time, but the emergency situation is the acidosis and the hyperkalemia that can actually kill the child. Huh?
Yes, sir.
Yes.
So total count is raised here, 15,000. Creatinine is within normal range. Electrolytes are within normal range. So there is no hyperkalemia.
The total count, unlike in adults, is normal. 15,000 is normal for children.
Yes, sir.
Up to 16, 18 is, I think 16 at least is normal.
Yes.
So when you look at even the range has been mentioned, I don't know. So what is worrisome here?
Hemoglobin, sir, only. Hemoglobin is...
What is the normal hemoglobin in infancy?
It is higher, sir. It is more than 13.
Yeah, it's 15 to 18.
Yes, sir.
Okay. The adult values are different and pediatric values are different. So you should be knowing all this. Anyway, what about the creatinine? What is the normal value for this age children?
So around 0.4, sir.
Yeah. How will you calculate the GFR if you are asked to? In this case, it is normal. Let us say
Yes,
it is
sir.
little abnormal. How will you calculate GFR? You know any formula?
Yes, sir. In infants, sir, it is based on height, sir. You can
Formula.
0.5 into height divided by serum creatinine, sir.
I know. I asked you the name, formula name.
Shorts for a moment.
Yes. Okay. So we'll proceed to ultrasound. Anyway, culture is positive.
Yes. So, image is showing the right kidney.
No question. Huh? The patient in the list. Ask the patient in the very good.
Please keep talking, you know.
What's the difficulty, Priyanku? Just go ahead. No, shows the right kidney. What does it show in the right kidney? Is it normal, abnormal? If it's abnormal, what's the abnormality? Let's move on.
So, showing hydronephrosis with cortical thinning.
Okay.
Size of the kidney is increased, sir. Length and all the in 3 dimensions into length and breadth has been mentioned here.
See, you can sum up all this by saying there is global hydronephrosis with cortical thinning. Correct?
Yes, sir.
Finished. Come on, Baba, let's see the next one.
So,
Is there any difference between that kidney and this kidney?
So both are right only.
what right kidney only, sir, mentioned.
Both are right, is it? Oh, okay.
Yes, sir.
Maybe that was a zoomed in image.
I'm saying this child has got infantile polycystic kidney.
Sir, here the dilated system seems to be connected to one. So it is not a polycystic kidney. In the polycystic kidney, sir, they will be not connected to each other, sir.
Are they showing all these things connected up? Or there are some hypoechoic areas lying separately?
There are some hypoechoic areas lying separately, but in one particular cross-sectional image, we cannot make out, sir.
It is important in the light of the history of this child.
Yes,
You
sir.
have to look at these images very critically. While there is doubt about the fact that there are some which are connected up with the main so-called pelvis, it is important to note that not all of them are connected and there may be a reason for it. It's important to figure that, okay? Because this is a congenital problem and you know that some kidneys can be associated with cystic disease, alright? So, anyway, you have to compare all the films. Carry on.
This image showing the left kidney, which is showing mild splitting of the complex with maintenance of the corticomedullary gradient, and there is no evidence of any cortical thinning. So mild hydronephrosis is shown, sir. And then we have an image of the right ureter, sir, which is shown to be dilated. So there is right-sided hydroureteronephrosis, sir, and left hydronephrosis. Right-sided side is more gross, sir.
Priyanku, you have to tell them whether to stay here or to move on.
Yes, sir.
If there is something more you want to see, we are waiting for you to give them instructions.
So, next image, next.
That's okay. You can go to the report. If that's all you have, go to the report.
So report shows severe right-sided hydroureteronephrosis, sir. Normal left kidney.
What is it not show? Is there anything that you anticipated, expected, thought would be there, but is not seen?
So left-sided hydronephrosis was also anticipated, which is not seen, sir. It was present in the prenatal scan, sir.
Okay. Anything else?
Would you like to see something more in the bladder? They have said urinary bladder appears normal. But
Bladder appears not. Bladder, yes, sir. There could have been thickening of the bladder or trabeculations, findings of hypertrophy or altered bladder wall ecotexture, sir. So here it has been mentioned
there
as
is something else inside the bladder. So accounted for this right-sided hydronephrosis. Could there have been something else inside the bladder? Dr. Mohan mentioned this condition some time back.
So any diverticular or seculations?
Not diverticular. Then there be uretrocele.
Uretrocele, yes.
No, so you see, the ureter only is dilated Sometimes, it's very difficult to actually miss the urethral diagnosis on ultrasound because it's pretty classical. But sometimes, with all the debris around and the infection, you might actually miss it. So you have to be sure that you're doing the ultrasound properly. So just as a question I asked you, it's not that it's happening here.
Okay.
You have to consider all these possibilities. Unilateral hydrourethral nephrosis.
So, Priyanka, with the ultrasound till now, what differentials remain in your mind?
Sir, one is posterior urethral valve that still remains, sir. Then
Posterior urethral valve remains.
You've seen the ultrasound.
yes, sir.
That was one of the points that I wanted you to note,
Yes.
which was negative. What was negative?
So lip-sided hydronephrosis is not present, sir.
In the posterior urethral valve, how will the bladder look and how will the bladder outlet look?
So bladder outlet will be dilated, sir. The posterior urethra remains
That's
dilated.
not seen, correct?
Yes, sir.
It is important negative,
Yes, sir.
has to be mentioned
Yes, sir.
so that the discussion moves into something more relevant.
Yes, sir.
Okay, we don't agree with the PUV. Anything else is a possibility?
Sir, vesico-ureteric reflux would be still
Good. Anything? One. Next. Only one?
Sir, obstructing vesico-ureteric junction obstruction on the right side, sir.
What is the condition called?
Right-sided obstructing megaureter with
So, how will you proceed now? You have these differentials in your mind. So, what is the next thing?
Sir, I would like to perform an MCU on the child, sir.
This child has come to you with history of recurrent fever. That's where they've come. And there is some whitish discharge or
Yes, sir.
urethra,
First-
or the urine is cloudy white.
Yes, sir.
You want
First,
to
I
do
will
the
treat the
MCU now?
child. Sir, I would like to treat the child for the urinary infection, sir, as per the culture reports. Put him on
Culture
antibiotics.
reports take 48 hours.
Yes, sir.
You wait for the culture reports. Here is a
It's done.
child, 9 months old, antenatal bilateral hydrourethral nephrosis, come to you with fever, incessant crying, difficulty in passing urine, passing
Sir,
whitish urine, or there is some whitish discharge per urethra every time the child passes urine.
Yes, sir.
And here you are.
Sir, I would drain the bladder, sir, by putting a feeding tube.
Praveen, please don't interrupt with the chat. We know you know. He has to think.
So we drain the bladder, sir, and we'll start him on broad spectrum and antibiotics, sir, cover, sir.
So wait. You want to drain the bladder. So what are the indications for draining the bladder in a situation like this? All children? Or do you have something to say, no, this child doesn't require a catheter? Because at 9 months, very difficult to both catheterize and to maintain the catheter. The child will cry his heart out.
Earlier, only the child was crying, now the mother also will start crying.
Okay, will guide you a little. The indication for catheter drainage in children has to be chosen more carefully than in an adult who we suspect of having bladder outlet obstruction. So, in children, what would be absolute indications for catheterizing the bladder?
Answer the question carefully. Think about it. Absolute indication.
So crying during voiding, sir. The repeated spells of crying during voiding.
That's the bag. Thanks.
The child will cry even more with the catheter.
Is it based on the crying or some evidence, man?
Recurrent bouts of fever is there, sir, with underlying infection. Due to underlying infection.
No. See,
recurrent bouts of fever you can address in several ways. You don't always catheterize. What is that set of conditions, 1, 2, or 3, where you'll say, no, this child has to be catheterized stat before we proceed. And then we will send the culture, we'll treat the fever, we'll give antibiotics, we'll do all that.
Presence of hydronephrosis, sir.
No. Presence of hydronephrosis, you will not catheterize. You will put PCL, no? I mean, he's asking a very specific. Priyanka, what's difficult, man? What is that absolute indication where you will catheterize the bladder in a child with fever like this? Obviously, the bladder is the problem, isn't it? The lower neck is the problem. So, what will they be?
He's having retention, sir. Palpable
Bladder.
Palpable bladder.
Retention with sepsis is an indication.
Don't we do this in patients, in children who come with posterior urethral valves? They come with fever, palpable bladder, thick walled palpable bladder, like a tennis ball, it will be sitting there, cricket ball, it will be sitting there.
Yes, sir, we do this.
You put a feeding tube, antibiotics, then proceed, isn't it?
Yes, sir.
Why is there nothing? I mean, nobody is asking a trick question here. It's all very straight. Don't think there's a catch in it. Even in the exam, Priyanku, there is no catch in any question.
Yes, sir.
Some examiners may put it slightly differently, but be sure that somebody else will put the question differently to make you understand. But there's no catch. It's all just straight, and one would expect you to know these. Okay.
So I think he has really no exposure to pediatrics. So I continue my point that you need to have allied postings. Like I said, you have to go to radionuclear scanning, CT scans. You need to have an exposure to pediatrics also. You will get cases in exam. It is not that it is only adult urology. You can have a short or long case on pediatrics.
No, if there's a child with a posterior valve, it will definitely be kept for the exam, 100%.
Yes.
Even if it is not there, there will be a simulated exercise case, no question. PUV, VUR, disorders of sexual differentiation, urethral, in some form or the other, you will have these cases. There are very few to name, isn't it? PUJ, POM, VUR, PUV, that's it.
One suggestion is, you can go to a center with a high volume pediatric load, spend some time there before your exams. At least to understand clinical management, if not the entire gamut of pediatric urology.
Yes.
Clinical management, it will be very helpful because exam 100%, you'll have one case of pediatric urology, if not more. And incidentally, Praveen, for you, we don't use Foley catheter in a 9-month-old child.
Feeding tube, sir.
Which is, no, but this is Praveen on the chat.
Okay, sir.
So, again, I'm warning you, please don't interrupt other people.
Yes, sir. Praveen is at least better than Kamal and Sambhaji. They've not even landed up.
No, that's okay. when you are discussing, you should focus on the discussion.
Yes, sir.
Others can write down what comes to their mind.
Priyanku.
Oh, sorry, Manish.
Yes, sir. Priyanku.
I thought it was Priyanku.
Yes, sir.
It's today's presentation was very, very bad. So are you presenting anywhere other than on these occasional Zoom classes? Because it sounds like you're not having any discussions with anybody at all. So if that is the case, please find opportunities.
Yes, sir.
Please present more and more often. You're appearing for the exam this year, right?
Sir.
Yeah, in your first year, if you sounded like this, we would have accepted it. But if you're exam going, then you have to be much, much better than this. So please find out, go to cases and chapters which you think you have never discussed, like this antenatal hydronephrosis, identify them and start presenting it to your consultant.
Yes, sir.
Anyway, you wanted an MCU. I don't know what has been done. Yeah.
In the filling phase, sir, the bladder appears to be well distended with no irregularity on the outline. No.
Hello? Hello? Can you look at that, please? I was just about to ask you what's the difference between what the ultrasound showed and what you find here.
Sir, bladder wall appears to be thickened, sir. In the first image, it's
more than thickened, Priyanku.
Slightly.
You can make out that it's irregular, isn't it?
Irregularity, sir. In the first image, sir, it is irregular.
Especially at the base, even on the lateral sides, you can see that it's irregular.
It's irregular, sir. And thickening is also noted, sir. Irregularly.
Wavy outline. You see that wavy outline on the side.
Yes, sir.
The importance of looking at these two films is that you can see certain changes when the bladder is slightly underfilled. At the same time, the bladder is able to be distended. And some of these changes are seen better because you know this child has had an infection. So immediately there should be a bell ringing. Oh, the child has had a urinary tract infection. The bladder wall, bladder lining must be very edematous, maybe angry looking. So what would be the image findings in that situation? And that's very clearly seen here. Okay?
Yes, sir.
Yeah. So try to correlate your clinical everything with the image. Yeah. Don't take anything in isolation. Okay, anything else? Any more films?
Yes, sir. Sir, voiding films showing left-sided vesico-ureteric reflux and dilatation of the posterior urethra, sir, with up to the level of the verumontanum. So,
I'll suggest to you one thing, Priyanku, when you present something like this, deal with the kidney ureter, deal with the bladder,
yes,
then come down to the bladder outlet and the urethra.
yes, sir.
If there are no findings in the kidney or the ureter, you can eliminate that part of the discussion, come to the bladder. If the bladder is also normal, there are no findings, then come to the outlet and the urethra.
Okay, Priyanku, how do you think they did this MCU for this 9-month-old child? It's a lovely image. It's a lovely image. So how do you think they did it?
Sir, by putting a feeding tube, sir.
Okay, they filled the bladder, but how did they do the voiding?
Sir, for voiding to wait, sir, for spontaneous voiding, sir, and with dynamic fluoroscopy.
Priyanku, you remember the ultrasound findings and
Yes,
then tell us what is surprising to you and what is the diagnosis finally?
So in the ultrasound finding the bladder outlet, we didn't get any positive findings, sir. But here we are having where you can see dilatation of the posterior urethra, sir. That is one difference. And there was no evidence of hydronephrosis in the left kidney, sir. So
There was an image in the ultrasound which showed hydronephrosis, though it was not reported. But
yes,
there
sir.
was gross hydro on the
Left
right
kidney,
side.
yes.
But it is not seen on the
Right side, yeah.
And
Left
this is a
side.
common problem with the residents everywhere, that you want to look at CT reports and ultrasound reports and not look at the images. With ultrasound, at least I would accept that, okay, the image is inadequate. But for CT scans also, most of you tend to read reports and then try and manage patients. Please don't do that.
So, what is the finding at the bladder neck? What is the finding in the rest of the urethra? Why is the prostatic urethra so dilated?
Yes, sir.
Have you seen X-rays of posterior urethral valve?
Yes, sir.
No, you've seen.
Yes.
Then
Yes,
what is the difficulty in answering these questions?
So dilated posterior urethra with constriction at the level of the perimontinum, sir. It is likely to be posterior urethral valve, sir.
What about the other question that Dr. Prabhu asked you? Before the posterior urethra, I asked you something about the bladder neck.
Bladder neck is wide open, sir.
Wide open.
It's wide open. Somebody seems to be pinching it.
It is hypertrophic, sir.
What is the term used to describe the bladder neck in a posterior urethral valve?
Sir, high bladder neck.
No. Prabhu will not be happy unless you use that word.
So many people won't be happy.
There is a particular term used for it, and it is very apt. That word is very apt, actually, when you look at it. What is that part of the anatomy, Priyanka, which stretches from one acronym to the other?
Bianco, this is the neck. So
Yes,
what
sir.
should this be?
Put him out in the misery. This term is called shouldering of the bladder neck, all right? Remember it.
Yes,
It's a classical X-ray. This is shouldering of the bladder neck.
And you see some intraprostatic reflux also. There's a valve seen at the level of the apex of the prostatic urethra. There is grade 3 reflux or whatever in the left side, but why there is no reflux on the right side? You expected, and you did this study basically to look for the problems on the right side, but surprisingly there is no reflux. So are you happy with that?
Yes, it can happen in posterior urethral valve, sir. On one side, it can be reflux, sir.
No, he wants to know an explanation.
If you found it on ultrasound, you are not finding it on MCU. Why is it?
Sir, obstruction at the right vesico-ureteric junction, sir. That can lead to this type of findings, sir. That is why there is no reflux on the right side. Or
What obstruction you are thinking about? Is it there is a dual pathology, one at the posterior urethra and one at the VUJ, or you have a better explanation for that?
sir, the main primary pathology is posterior urethral valve, sir. There is no pathology at the absence of vesico-ureteric. We don't expect vesico-ureteric reflux, sir. So we cannot. That is why there is no evidence of any That's on the right side. So on the left side, that can, because of the pop-off mechanism seen in posterior urethral valve, there can be presence of unilateral reflux on one side.
Priyanku, isn't it very worrying that the kidney that appears to be normal on the ultrasound is the kidney that is actually refluxing?
Yes, sir.
One would expect that the pop-off will be on the other side to protect the good kidney. But this is popping off on the good kidney. Isn't it?
Yes, sir.
So isn't that a very dangerous situation? The right kidney is a lousy kidney, you said. Thinned out cortex, dilated hydro, like a big, hose pipe that ureter is.
Yes.
So this is a very interesting situation. So you need to figure out as to why this problem is happening.
Yes.
Yeah?
Yes, sir.
That's exactly what Dr. Prabhu wants to know.
Where was this X-ray taken?
IITV. So in
Was it in Puttapati or Dispur?
sir, Puttapati, sir.
Puttapati. Hardik, whenever you take MCUs, even on the full bladder, make sure there is an oblique film.
He's
You get the point?
Hardik, are you there?
he is not there, sir. Not present, sir.
He's not present. His case. Anyway, for the others. Because
Yes.
diverticulum might be masked by the AP view and might empty out later.
Yes.
So you can miss it. If you look at this X-ray here, there is a diverticulum clearly
Yes,
in the
sir.
film on the left.
You see, this is a very interesting situation here. It's very important for everybody to understand this. That why is there no reflux on the side that is the lousy side, whereas on the good side that there is a reflux? The importance of that oblique film on the full bladder or lateral film will show us whether there is a reflux which is hiding behind and in the retrovesical portion. So you can't see that sometimes because of the contrast. So an oblique picture might show you that wisp of contrast going up, number one. Number two, there could be an anatomical reason for obstructing that ureter, although it is refluxing. One would expect that if there is a Hutch diverticulum, that there would be an associated BUR, but not necessarily. So if there is a diverticulum, sometimes it can obstruct that side orifice and prevent reflux from going up, and therefore will cause more obstruction sometimes. And last but not least, you can still have a primary obstructive megaureter on one side and a PUV also at the same time. So any possibility is there. You have to think of everything. Doesn't mean that, it's not possible.
Okay, sir.
So you see that you have, in the exam, you have to be thinking on your feet all the time. It's an unfortunate situation, but what to do? So the more you see these types of cases, the more you introspect on them, you will be able to take it. So this is a very interesting situation. Remember this case.
Yes.
Yeah.
So Priyanku, what do you want to do now?
Sir, I'd like to go for definitive management, sir, in case like.
You are giving
Stop
a
at
weak-
like, it means you're not clear. Rather than use terms like definitive management, temporizing management, and so on, you can specifically say
Yes.
these are going to be my steps in management, or this is my algorithm. That will help you. It will help you think the examiner's way and answer the next question that will automatically come.
So once I have drained the bladder and put the patient on IV antibiotics, after once he is stabilized from the infective process, I'd like to go for valve fulguration.
Is your imaging over, or is all your information done before you decide to manage this child?
We can go for a functional scan, sir.
Can go, will go,
We will go for a
better
functional.
go. here, Priyanka, when you answer, you have to also consider that before any intervention, we should, even the first intervention in a series, we should have an idea of what all is required. Now, the entire right side, we know nothing of what's going on.
Yes.
Correct? Second, when we're intervening at this age, everybody is going to be worried, including the parents and yourself, about what's happening to the left kidney, what's happening to the right kidney. Will this cause renal failure? Will there be other complications? Which means the investigative protocol must be complete in its non-invasive section before you decide to do anything invasive.
Yes, sir.
Dr. Prabhu's question is, have you completed investigating?
We should go for a radionuclide renal scan, sir.
Sorry?
Radionuclide renal scan, sir. Functional scan. So,
No, functional scan, do you want to see why there is hydronephrosis on the right side? Will a functional scan show that? You have not picked up a reflux.
See, Priyanka, you have to specify what test you want rather than giving a functional test. I don't know what is in your mind. If you have told something like I want DTPA or MAC3 or EC scan or DMSA scan, then we can get an idea what you are thinking.
so MAC3 scan if available, sir. But you can also go for an EC scan, sir.
So we'll stop here. It's about 9:10 now. Yeah, we have EC scan, the management. That's okay.
Valve fulguration was done in this case, sir.
I don't understand the term spiral valve. But, okay, let it be at that.
So thank you, sir. We will cut short.